All right, so let's have a look at effusions. So effusions are an abnormal amount and or type of fluid within a body cavity. Common locations, which I'll talk about, are pleural, peritoneal, and pericardial, and it can result from an inflammatory or non-inflammatory cause. So effusions essentially are fluid in a cavity in the body. The effusion itself is not a pathological disease. However, the presence of fluids, so the presence of effusions, indicates that there is a pathological process in the fluid production and removal system somewhere in the body. So effusions are a symptom of a disease process. Location, like I just said, can be the pericardial, visceral, or pleural cavity. And they can be normal fluids found in expected sites, could be abnormal fluids found in expected sites, can be abnormal fluids found in unexpected sites, etc. So you could have a copious amount of normal abdominal fluid. You could have an abnormal fluid that suddenly appeared in the chest, etc. So there's different types of fluids, and you have to get to know, in general, the normals and abnormals and amounts for what's normal, what's abnormal. So we'll go through each of these. So the visceral, pleural, and pericardial cavity. This is an example of pericardial effusion. So this is it showing up on X-ray. And you can see here that the heart looks extremely bulbous. It doesn't have a nice identifiable apex. And that's because that thin layer between the myocardium and the outer aspect of the heart, so the pericardium, that layer between the pericardium and the myocardium normally has a small amount of fluid within it. That's normal. That allows for lubrication while the heart's expanding and contracting. And pericardial effusion happens when increase in fluid in that pericardial space occurs. And on X-ray, it's impossible to tell on X-ray whether it's a true pericardial effusion or if the myocardium is actually enlarged and is abnormal in shape, because all we're seeing is a 1D image of a round bulbous heart. But this is fairly typical presentation on X-ray for pericardial effusion. So pericardial effusion, cats, it's typically secondary to heart failure, so to congestive heart failure, or secondary to FIP, feline infectious peritonitis. Primary cause tends to be cardiac neoplasia, such as lymphoma, and that's in cats. So cats' primary cause of pericardial effusion is cardiac neoplasia, such as lymphoma. Secondary is congestive heart failure or FIP. Dogs, the primary cause is cardiac neoplasia. And of all the cardiac neoplasias that are out there, hemangiosarcoma is the #1 most common. Also, hand in hand, it's almost 50% one way or the other for the top spot, but another cause of congestive heart failure for dogs is idiopathic, not congestive heart failure, pericardial effusion is idiopathic reasons. So reasons unknown, just suddenly comes on and then has to seek treatment for it. So generally the #1 cause of pericardial effusion in dogs is cardiac neoplasia. The #1 cardiac neoplasia in dogs is a hemangiosarcoma. And secondary, it would just be idiopathic. So for dogs, for cats, we're looking at secondary would be congestive heart failure. That's potentially treatable. FIP is not. We'll talk about FIP a fair bit. And the primary cause in both dogs and cats is cardiac neoplasia. So it's not really ideal causes. So when we're seeing pericardial effusion in animals, it's not necessarily the best symptom of a disease to see, because it doesn't always mean a treatable good thing, treatable illness. Then we have abdominal effusion. So this is typical presentation for abdominal effusion. You can see that there's an opacity throughout the abdomen, and you can see some gas patterns, but you can't see the outline of various soft tissue organs. So it means that there's fluid in the abdominal cavity, in the visceral cavity. Typical presentation for dogs and cats with abdominal effusion would be lethargy, decreased in stamina, abdominal swelling, especially in dogs more so. And when you perform ballottement, so when you push the abdomen, the fluid wave occurs. So it bounces right back and creates sort of a tympany of fluid wave. So it's hard to, I couldn't find any good videos to show this on animals, but if you're ever in clinic and you happen to see an animal that has a large abdomen and think it's maybe fluid, if the vet does ballotment of the belly to see if there's a fluid wave, just have a look, try to have a look, because it's interesting to see how the fluid bounces back at the hand once it's been removed. And just, we'll talk about, actually, with abdominal effusion, which is kind of neat with cats are tricky. So when they have abdominal effusion, most of the time, what they'll do is decrease their energy requirements. Same with when they have pleural effusion, so thoracic effusion. Cats are cool, they adapt in a way, but they also hide everything in a big way. So instead of showing their owners that they're sick and that they're not doing well, evolutionary-wise, they start to decrease their energy requirements. So cats do that fun old hiding. So they just hide, and they're very quiet, and they just hide. So the owners might just come in and say, you know what, she's just not right. Something's just not right. So cats are kind of neat in that way. But dogs typically decrease in stamina, abdominal swelling with the fluid wave, and lethargy is quite common for abdominal effusion. Sorry, wrong way. Pleural effusion. So pleural effusion, you're getting the same kind of effect as we had with the abdominal effusion on X-ray. The pleural cavity, though, so thoracic cavity, is opaque. So there's an opacity, and that's fluid that's distorting the view of the soft tissue organs in there. Most common symptom of pleural effusion is dyspneic breathing. So difficulty breathing. They might have, especially with cats, they tend to have increased abdominal effort during respiration and increased effort in breathing in general. Cats often come in open mouth breathing, which we know is not normal, and we want to definitely seek the assistance of a veterinarian if we see open mouth breathing in cats. They may or may not be cyanotic. It depends how well their carbon dioxide is escaping. It's not building up too much. And you see them come in, dogs especially have oftentimes, well, dogs and cats will sit in sternal. If you try to restrain them in lateral, they're very uncomfortable and they'll sit in sternal position rather. And you'll see dogs extending their neck and extending their head, trying to get a breath, trying to get a full breath of air. Dogs and cats that have, well, more so dogs that have chronic pleural effusion, so mild pleural effusion typically, the only difference the owner might notice is they've increased cough, the frequency of coughing. So they'll be coughing a little bit more than usual. Cats, it's never ever normal for cats to cough. They tend not to do that. So if they're coughing at all, then definitely have them seen. So this is a picture of ascites, so swelling due to fluid in the abdomen. It's a little Jack Russell. So this is a needle getting inserted into the abdomen, just past the abdominal wall and the muscle to collect some of the fluid. So for collection, when we're collecting any sort of effusion, you need to have a couple of tubes ready. You want to collect 3 to 5 mils in EDTA for in-house cytology and cell counts, and then use a red top tube as well for separate CNS testing, so culture and sensitivity. Main thing is process these samples immediately, just like anything we're ever going to talk about with cytology. So this is abdominocentesis that's occurring right here, and this is a plain old needle. Depending on the size of the dog or animal, sometimes an IV catheter is placed in the abdomen through the abdominal wall, and then the stylet can be removed, especially as well with thoracocentesis too, to help avoid piercing any organs as that animal is having increased respiratory effort, etc. Oh man, sorry, I gotta get my keys right. I'm gonna make you guys dizzy. And then this is a cat undergoing thoracocentesis. The main thing is a lot of times when these animals come in for this type of centesis, Maybe sedation is needed. A lot of times they don't need sedation. Typically, they're so lethargic and just not feeling well that they tend to stay happily in place while the fluid is removed from their thorax or their abdomen. And then for your samples, we said to collect some in EDTA. The main thing with EDTA or your samples in general that you're going to use for cytology, process immediately. Can't stress that enough. Most of the time, unless it's an extremely cellular sample, then you'll need to centrifuge these fluids down. So for 5 minutes on a urine setting in the centrifuge is acceptable. Centrifuge them down and then draw the cells from the very bottom of the tube. Then, of course, depending on the type of fluid that you've got in the bottom of your tube, you're going to apply the appropriate smear technique. So if it's thin, think about a line smear, especially if it's thin and clear, such as a Transudate, then a line smear would probably be most appropriate. If it's blood, hemorrhagic or otherwise, or like a blood-like consistency, then you can just do a typical blood smear, a wedge smear. And then if it's really thick, of course, we're going to do a squash prep. Staining is going to depend on what your suspicions are about the sample, but typically we do a diff quick stain on at least 1 or 2 slides, have a look. If you're suspicious of fungal or bacteria infection, then you might want to choose a gram stain. Otherwise, diff quick and rate stains are completely acceptable. So moving on, we're going to get into effusion assessment, and we're assessing the fluid that we've removed based on these physical characteristics: protein, total nucleated cell count, cytology, PCV, chemistry, and then of course culture and sensitivity if it's required. So the purpose of all this effusion assessment, in part, is to identify what type of effusion we're looking at. And we'll go through each of the types, but we've got transudate, modified transudate, and exudates. And each of those has a particular class of diagnoses, although some are more diagnostic than others. But they can help in the diagnostic process, knowing the difference between all of them and ruling out various disease processes because of the physical characteristics. So here we've got various colors that we're going to look at. So from left to right, we have clear and colorless, typical of a transudate; yellow and slightly turbid, typical of a modified transudate; red and slightly turbid, is often in part due to hemorrhage. Then we have orange and turbid, likely inflammatory fluid with some blood. Then we have sedimented fluid, and just note the thick pellet of cells in the bottom of the test tube after centrifugation. Then we have red and turbid, so bloody as a result of either hemorrhage or iatrogenic blood contamination. And G, I don't know why I said G, it's because I have it written down in alphabetical order. But the last one, we have brown and slightly turbid. When you see it, it could be bile or significant red blood cell breakdown. So then for each of these samples, we would look at volume. So how much fluid are we actually removing from the animal, or are we assisting with removing from the animal? Color, transparency, so is it opaque, is it clear, is it mildly cloudy, is there flocculence before and after centrifugation? Consistency, is it thick, is it thin? And then of course if you notice any odors as well. We're also, let me just go back a bit. So going back to this slide here, so those are the physical characteristics. And then we also look at our sample, the protein level of our sample, total nucleated cell count, and then of course cytology, PCV, etc. So for protein, we're looking at total protein. And there's a couple ways to determine total protein. In clinics, the most efficient and cost-effective is, of course, using a refractometer. They're best used with clear effusions, and typically your effusion has to be quite clear after centrifugation. So some of the fluids that we're going to talk about, such as a chylous type fluid that's quite lipid-filled and white, won't necessarily read with your refractometer. You can also use a urine dipstick, which generally works, but of course not with a colored sample. Then we would look at the total nucleated cell count. So again, we're going to go back to that hemocytometer, which you need to remind me to show you in lab if we have one. So that's looking at the total nucleated cell count using the hemocytometer. So same idea where we're placing our sample onto the slide and then onto the counting grid to assess how many cells per mil. And then there are also computerized cell counters as well that we could put it through the machine to analyze. However, sometimes it misses clumps or fractured cells. So then we would move on to cytology, which we'll talk about in specific for each type of effusion that we're going to look at. But with cytology, of course, you're assessing the identities and morphologies of cells within the fluid to help determine the cause of the disease, because certain disease processes have certain cells associated with them. The disease progression, so the age of the cells, the degree of activity. Monitor the therapy, the efficacy of the therapy. So if the animal is on antibiotics or if they're on heart medication, that kind of thing, how many of these cells are you still seeing in that fluid sample? And that goes hand in hand with volume. How much of the fluid are you still seeing? Is that treatment program actually working for the animal? And then, of course, the types. Are we seeing inflammation, neoplasia, or non-neoplastic, non-inflammatory? Likewise, are we seeing infectious agents such as bacteria, fungus, etc.? Okay, so I'm just going to bounce forward a little bit. Sorry about that. Make you sick with car sickness, Prezi sickness. So then we could also look at clinical chemistry. So a lot of this fluid that comes out, once we spin it down, we actually can run it through the blood analyzers to get a clinical chemistry on it. And again, that could also measure the protein too, which is helpful in clear fluids. So a couple things that could be associated with changes in clinical chemistry. You might be looking for bilirubin, so to show some hepatic involvement, like a bilious fluid, triglycerides, cholesterol. If we're suspicious of a uroperitoneum, which is urine in the abdomen, so perhaps if it was a blocked cat or a suspected blocked dog, and their bladder has ruptured in the process of assessment and starting treatment, and we want to confirm that yes, the fluid in the abdomen is a ruptured bladder, which is really unfortunate, then we can actually run that fluid through the clinical chemistry machine, and the urea, nitrogen, creatinine, so BUN and creatinine, would be increased. It would be higher in the effusion, so in the fluid, than in the blood. So that would be indicative of uroperitoneum, which is really unfortunate. It happens, but you have to get that animal treated ASAP, into surgery, open up the abdomen, flush out that abdomen, because of course urine can't stay in the free floating in the abdomen. So if it stays in there for any period of time, it can start to be corrosive on the organs and can cause a major inflammatory reaction. And of course, worst case is if we don't catch the fact that it's uroperitoneum, that animal could die. Now, always think about this though. Always, always, always. If you have an animal that comes into your clinic and you suspect that they're blocked, so you have a blocked cat that comes in and you're gently palpating the bladder to confirm that it feels like a blocked cat, do not palpate that bladder firmly. Regardless, we always know that the vet still has to go in and assess and palpate the animal. All we need to do is locate the bladder, feel that it's firm and perhaps it's a little bit enlarged, but do not apply a lot of pressure. I also don't recommend that we try to express the bladder at all until the veterinarian has seen the animal, because I've seen it happen where somebody has tried to express the bladder and they rupture the bladder because that cat perhaps has been blocked for 24 hours. We never know, so just be extremely cautious when you're assessing blocked cats and dogs, or potentially blocked cats and dogs. The other, before I get into classification, the other criteria that you might want to look out for is the presence of bacteria in the abdomen or in the thorax, in any of those fluid, so the effusion samples. So for that, if bacteria is suspected or if a fungal organism is suspected, then definitely take some fluid, put it in a nice sterile red top tube, and send it. Have your veterinarian will send it out for culture and sensitivity. And specifically, they could be looking for aerobic, anaerobic, fungal, mycoplasma, etc. Sorry, I keep doing that. Okay, so let's get into our 3 classifications of effusions. I'm going back to this one. So we have transudates, modified transudates, and exudates. Transudates. Transudates are fluids that are typically clear. They have a protein of 2.5 grams per deciliter or less. And when we're counting their cells, we get a total nucleated cell count of less than 500 cells per microliter. Lots of volume. Typically, transudates produce high level of volume. And it's an abnormal volume of a normal fluid. So essentially, a transudate is a normal fluid that floats around the body, is covering the organs, is helping everything move around together, but it's being produced in copious amounts. The exception to these rules, so one exception is equine peritoneal fluid has normal values, their normal values of nucleated cells. I'm going to ignore that for now. Let's see here. Sorry, so I'm just trying to word this appropriately, but essentially equine peritoneal fluid, normal equine peritoneal fluid, has been documented to reach up to 2,000 cells, total nucleated cells per microliter. So the one exception is equine peritoneal fluid. It would still be considered a transudate if it's up to 2,000 nucleated cells per microliter. So lots of different causes of transudates. It's typically related to a decrease in oncotic pressure, most typically associated with albumin. So oncotic pressure is a form of osmotic pressure exerted by proteins. Again, most often the protein is albumin. And that type of pressure, oncotic pressure, draws fluid into the circulatory system. Okay, that's what oncotic pressure refers to. So if there's a decrease in oncotic pressure, that fluid's not getting drawn into the circulatory system. It's actually being left in the interstitial fluid and in the abdominal cavity, in the thoracic cavity, in the pericardial cavity. So it's a decrease in oncotic pressure. Hypoalbuminemia, can't say that very well, is a common cause of this. So that's typically one of the reasons that this is happening, because albumin is so important in drawing that fluid back into the circulatory system. So if we have low albumin in the body, that can cause transudates to accumulate in the abdomen or thorax. And that's typically caused by renal glomerular disease. So the glomerulus of the renal system of the kidney. Hepatic insufficiency is another cause of transudates, so another reason that transudates might start accumulating. And same with protein-losing enteropathies. And you'll hear that periodically in your life in clinics of these mysterious protein-losing enteropathies. If you have a uroperitoneum, so again, urine in the peritoneum, then it can start off seeming like a transudate, but very quickly it will change into a modified transudate with an increase in inflammatory cells. So modified transudates are essentially transudates that are modified by proteins, cells, or both. They have a protein level between 2.5 to 7.5 grams per deciliter. Total nucleated cell count is 500 to 800 per microliter. And this is fluid that was once a transudate that's been hanging around in the body long enough, causing trouble and creating an inflammatory reaction. So it now has the presence of inflammation. Typically, it can be yellow or pink. It can be a bit cloudy. Some examples of causes could be diaphragmatic hernia, pulmonary thromboembolism, mediastinal or pleural neoplasia, FIP, and chylous effusion. A modified transudate is the least specific in regard to finding a diagnosis. So it's the least specific. If we get into transudates, there are only a certain number of things that can cause normal fluid to accumulate in such volume. When we get into exudates, again, there's a handful of things that can cause them, but modified transudates are the least specific in diagnostic value. The number one cause of modified transudates is neoplasia in the heart, so cardiac neoplasia, and cardiac disease. So the two of them are the number one cause. Cardiac disease, presentation, if it's cardiac disease, whether it's, well, in general, if it's neoplasia or true pathological cardiac disease. So the typical presentations for cardiac disease in regard to modified transudate, cats get pleural effusions more than dogs, and dogs get peritoneal effusions more than cats. So cats tend to show things, effusions in their chest faster than dogs, and dogs tend to show it in their abdomen more so than cats. Now, cytology in regard to modified transudates, if it is, especially if it's thoracocentesis, so you've done you've taken pleural effusion, so pleural fluid out of the chest, and you're expecting to find maybe some cancer cells, because we know that cardiac neoplasia is tied with cardiac disease for the number one cause of a modified transudate. So essentially, we're going to take some fluid out of the chest, and then as an RVT, my job is to run the fluid, look for abnormal cells, see what I'm finding. It's not overly common to find some cancer cells in thoracic fluid and in abdominal fluid for modified transudates. If it's a round cell or epithelial cell tumor, then yes, sometimes you can find them and get an idea that it is neoplasia. However, if it's something like a hemangiosarcoma or in general a mesenchymal type neoplasia, they often do not show up in effusions. So oftentimes, which again, I'll talk about later, but hemangiosarcomas are quite common to cause modified transudates and exudates. Well, no, modified transudates for sure. But if it is a hemangiosarcoma, because that's a mesenchymal neoplasia, you tend not to see them very well in these fluid samples, which is unfortunate. So you don't get diagnostic criteria from them sometimes. And then there are various types, specific types of modified transudate, one of which is Chylothorax. And Chylothorax I'll talk about a little bit later on as well. Chylothorax is kind of neat. Maybe I'll leave the talk about it for a little bit later. But when you have a chylothorax or a chylous abdomen, then it's a white or milky fluid that's coming out. It's a thin fluid, but it's fairly opaque in color. And that's a cat having pleural fluid removed. And the cat's fairly happy, just hanging. Okay, exudates, as you can imagine, think pus, think thick. So exudates, protein typically is greater than 3 per deciliter, and total nucleated cell count is greater than 3,000 per microliter, which is really, really, really high. So these are abnormal fluids, high in total solids and nucleated cell count. They can be turbid, pink, yellow, high protein, high cellularity. Predominantly neutrophils is what you'll find in these, and therefore they could be septic or non-septic. So we always have to keep an eye out for microorganisms hanging out. So if you see a lot of healthy neutrophils, so hypersegmented neutrophils, not terribly karyolytic or karyorexic, then that's typically most likely going to be a non-septic sample. If you're seeing tons of degenerate neutrophils, keep an eye out for bacteria. In general, in life, degenerate neutrophils, look for bacteria and other microorganisms. And it's super important with exudates, if you're seeing lots and lots of inflammatory cells, to send out for culture and sensitivity. Pyothorax is the term given to pus from the thorax. So this dog, looks like a little Jack Russell, has a drain in its thorax that's removing a whole bunch of pus. All right, so cytology, normal or abnormal? So normal to see in normal fluid in general, so typically transudate, normal fluid, mesothelial cells in low numbers, occasional white blood cells in low numbers with normal morphology. In dogs and horses, neutrophils dominate. In cats and cattle, you tend to get more lymphocytes coming out. And then you might also see some that's not a real word, eosinophils, maybe some mast cells, but in very low numbers, and perhaps some red blood cells. Mesothelial cells, we all know by now, I think, that they can look very different depending on what's going on. They can become activated, they can become reactive. When they're reactive, that's when you tend to see the multinucleation and really dark basophilic cytoplasm. So just going back to regular cytology, let's go back here for a second. So if you're looking at a transudate, it's just, you might see the occasional white blood cell, essentially. That's what you're seeing. Occasional white blood cell, a couple of mesothelials sprinkling here and there. Modified transudates has those cells, plus you might start to see reactive mesothelial cells, and mesothelial cells will start to become reactive if inflammation is present. So they start to change in the face of inflammation. So you might see some reactive mesothelial cells, might see some non-degenerate neutrophils, or degenerate neutrophils if there's a sepsis occurring. And then exudates, typically it's inflammatory, so follow all the rules of classification of inflammation. And you tend to get like a serious inflammatory response in exudates, where it's essentially just a big pus smear. So let's talk about FIP a little bit, feline infectious peritonitis. It's a really, really interesting virus. It's really unfortunate for cats. So essentially there are two forms of FIP. There's effusive FIP, which is what we'll talk about in most detail, and then there's also dry FIP. And dry FIP tends to be associated with a chronic FIP. And FIP in itself is initiated by the coronavirus, by the feline coronavirus, and the feline coronavirus will get into the body, undergo a mutation, and then start to replicate. And that replication and mutation is FIP, is feline infectious peritonitis. And it's spread between cats, which is really unfortunate. So dry FIP is typically chronic. The cat tends to be waxing and waning with clinical symptoms. So just sort of not right sometimes, not meeting their full potential in regard to energy requirements. They might be here and there with food, a little bit of an appetite sometimes, sometimes not, perhaps decrease in weight. And then they can start to see a little bit of jaundice as well because the liver starts to become affected. Also, what I thought was really interesting is cats with dry FIP can get abnormalities to the iris of their eye, typically of one eye, not often bilateral, but to one eye. So in the iris, they can start to see color changes. So always keep this in mind. Tip. FIP tends to happen to young cats between 6 months old and 2 years old. If they live with other cats or outdoors, they have a higher chance of getting this disease. So if you get a cat in that's kind of waxing and waning, has some weird discoloration to their iris, keep that in the back of your head. We're not diagnosing it, but sometimes if that's on your mind, you're always welcome to gently suggest that or see if that's something to rule out. If a cat is suspected of having a FIP, you can run some antibody tests, and the cats that do have FIP have a very, very high feline coronavirus antibody titer. So it's at least 1280 or above. So effusive FIP is what we'll be looking at in regard to cytology. And effusive FIP tends to be an accumulation of an effusion, so of an exudate in particular, in the thorax or in the abdomen. Protein is typically above 4.0 grams per deciliter, and most often we're seeing pyogranulomatous inflammation. The nucleated cell count varies. So it's kind of tricky because that way it can insert itself into a modified transudate or an exudate, depending on where it is in its progression. But the nucleated cell count does vary from low to moderate. So you tend to see 60 to 80% neutrophils, non-degenerate or mildly degenerate, and then some macrophages, enough to tip the scale into pyogranulomatous, and you might see some small lymphocytes as well, especially if it's in the abdomen. And again, this can be in the pleural or peritoneal cavities. The fluid the fluid itself for FIP, I'm sorry I don't have a picture, but it tends to be, it can be fluid-like, it can be quite thick. You tend to have clots in it, so big clots or strands of fibrin is pretty common with FIP. Also to just withdraw fluid from the thorax or the abdomen and have essentially pus come out in your syringe or hemorrhagic pus, that's not uncommon as well. Chylothorax. I see my image is a little bit wonky and shifted with the green here. But chylothorax, if you can see what this is, we're inside the thoracic cavity. So the vet has opened them up. I'm not sure exactly what's going on here because there are towels. I suspect perhaps this is a post-mortem, I hope. But there's this white milky fluid surrounding all the organs. So that's essentially what chylothorax or chylous effusion looks like overall. It's a white milky fluid surrounding the organs in either the abdomen, and it would be chylous abdomen, or in the thorax, and it would be chylothorax. The cause of chylothorax is typically a blockage of the thoracic lymph duct that normally empties into the venous system. So typically as lymphatic fluid is circulating around, it has a loop with the venous system to help recirculate and filter. So where that thoracic lymph duct naturally is, if you get a blockage in that area, then this lymphatic fluid is getting stuck. It's getting stuck in a cavity. So where there is a cavity, the body will fill it with fluid. So when you have a chylothorax, the animal, when we take the fluid off the chest or out of the abdomen, comes out as white or pink, and it's opaque. So it's very, very chalky white, opaque, or slightly hemorrhagic, might be pink. And when you spin it, it doesn't fully clear. So the supernatant will never go clear. Even though it's lymphatic fluid, you tend not to see a ton of lymphocytes in it. It tends to have fairly low cellularity. And most of the color of the white is because of lipids that are present. So the most common, various causes of chylothorax or chylous abdomen are neoplasia. Neoplasia is typically number one across the board. Granulomas or inflammation in the mediastinum. So all of that, so neoplasia, granulomas, or inflammation, all in the mediastinum, because that's where that thoracic lymph duct is. So then those become physical blockages. Or right-sided heart failure. So again, right-sided heart failure will cause a physical obstruction of that lymph duct and cause a distortion in the fluid placement. Chylous effusions typically have protein between 3.5 and 4.5 grams per deciliter. Low cellularity, which is always a little bit, I always expect to see more lymphocytes, and you never really do. So if it's fairly fresh chylous effusion, then you'll have typically some lymphocytes, a couple of macrophages kicking around. If it's chronic, so if it's been in there for quite a while, you'll get more reactive mesothelial cells, and you'll start to get neutrophils, so more of an inflammatory process happening. And then we can get hemorrhagic effusions. So hemorrhagic effusions can occur in the thorax, they can occur in the abdomen, that's what I was trying to say, and of course in the pericardium as well. Most common cause, it depends what's causing the hemorrhagic effusion, or the hemorrhage in the first place. And the vet has to determine if it's a constant hemorrhage that's currently occurring from an organ or a vessel, in which they might see platelets, or if it's one that's typically caused by a tumor or cancer or a rupture of a tumor or cancer. And in that case, typically there aren't platelets or extremely low number of platelets in the fluid. So hemorrhagic or if it's a hemoabdomen or hemothorax, typically the animal will present with the same abdominal or thoracic or pericardial effusion symptoms and signs. Also add to the mix probably some pretty pale gums, so pretty pale mucous membranes, and this dog's displaying very pale mucous membranes. Common cause that you see with hemoabdomen, even hemothorax or hemopericardium as well, is hemangiosarcoma. Very common in dogs, older dogs especially, where they have a tumor in any area, so on any blood vessel. Hemangiosarcomas can grow on any blood vessel. It's a big tumor and then it ruptures. And they come in and they have a bleeding tumor inside their belly or inside their thorax, and unfortunately they can bleed out. So you might find on cytological analysis are macrophages with hematoidin or hemosiderin inside the cytoplasm. You can just see hematoidin and hemosiderin kicking around on its own, and that's the big yellow crystals, and then hemosiderin's black or darker granules, sometimes brown, just kicking around. Predominantly you'll see RBCs, and then of course some activated macrophages displaying erythrophagocytosis and no platelets. That's key. And then we have bilious effusion, which is bile escaping typically into the abdomen. I don't know how often it happens in the thorax, but typically it's in the abdomen. So essentially bile that's accumulated in the abdomen. So the fluid itself, the effusion, can be light to dark green. So there's always a tinge of green or brown in the color. And as you can imagine, bile is very, very corrosive. Essentially, it's breaking down fats. And it will cause peritonitis very, very quickly. So again, if an animal is looking very lethargic, very painful abdomen, and then fluid that pulls out is sort of a greeny type color, bilious effusion is typically the cause, or what you're going to find out. And with bilious effusion, you can run it through your clinical chemistries as well, and you're probably going to see some increase in liver values. It's typically non-septic when we look at it under the microscope, and it typically has a protein level of that of an exudate. Chylothorax and choloabdomen, CHOLE being the prefix, is the term given to bilious effusion in the thorax and the abdomen. So our goals as RVTs in all these cases is to help the veterinarian take the fluid out of the abdomen or the thorax, which a group project will probably talk about, and then know how to prepare the fluid, know how to look at the fluid, stain it, and start identifying cells that might be familiar, and help the vet in determining a diagnosis through our diagnostic process. So through our laboratory work, we then provide that with the veterinarian, and they can decide what's going on and rule out some potential diseases.